Okay, now it is my pleasure to introduce our speakers today. I'm thrilled to introduce these two. I've had the privilege of working with them right now on another telesupervision project, and it's just so much fun to be a part of that team. They are such experts and professionals. I can honestly say, even me, honestly, can say I don't believe anyone is doing any more important foundational work in the area of telesupervision at this time. I'm not aware of anyone. So this should be fun. So Erika M. Shearer is a psychologist by discipline and the program manager for the Primary Care Mental Health Integration Program at VA Portland Healthcare System. Her areas of expertise include telehealth technologies to provide and increase access to mental health services, adapting evidence-based therapies to clinical video telehealth modalities, telesupervision, and integrated healthcare. In her free time, she enjoys cooking, baking in the Portland, Oregon restaurant scene, as well as hanging out with her children and giant dog. Shiloh Jordan is a psychologist and psychology training director at VA Pacific Islands Healthcare System in Honolulu, one of my favorite places in the world. Her professional interests include implementation of supervision and telesupervision, utilization of training and education of health professionals to promote care for underserved populations, and implementation of evidence-based psychotherapies for the treatment of PTSD. So with that, I'm going to exit stage left and turn it over to our speakers.
We do want to make some acknowledgments in the sense that we are both employees of the Department of Veterans Affairs, and the contents of this presentation do not represent the views of the VA or the U.S. government. And also want to acknowledge support of the projects that we're going to discuss from VA Office of Rural Health, as well as VA Office of Academic Affiliations, who are great partners with us in support of the work that we're doing and projects we'll reference today.
So we have two polls. Thank you all for those of you who did participate. Our first one was about your experience with telesupervision. And so for this poll, we have 40% of people endorsing that they have themselves facilitated telesupervision. We have 27% endorsing that they have received telesupervision, and 43% endorsing that they have neither facilitated or received telesupervision. So a nice mix of people with experience here. And then in our second poll, this was, what is your discipline and role? So we have 12% of our audience endorsing a nursing discipline, 6% endorsing a psychiatry discipline, 12% endorsing a psychology discipline, 28% endorsing a social work discipline, 19% endorsing some other therapist type discipline, and then the last category is other, and that is 23%. All right, I will advance the slide and turn it back over to you, Shiloh.
Thanks, Erika. All right, so we'll look at our learning objectives, what we hope to achieve in this little bit of time with each other today. We're going to discuss the rationale for in-person and video-based supervision experience, describe some of the considerations related to adapting supervision elements across these modalities, and then identify strategies to scaffold training experiences across the supervision modalities. All right, so let's launch into just looking at a current stance. So looking at your discipline, APA, Commission on Accreditation, telesupervision may not account for more than half of the minimum required supervision hours. And I know that actually some of the implementing regulations within APA, which psychology is my discipline, are under review to potentially expand this. ACGME, telesupervision may be permitted depending on the specific specialty. And we're just giving a slight overview here because we are not experts on any of our accrediting organizations, but we want to really be mindful of paying attention to what is accreditation standards and what is allowable. And AWSB, allowance of telesupervision and type and amount varies by state. And really, we want to make sure that the bottom line is really paying attention to this ever-changing landscape, that even as we prepared this presentation, there are shifts that may be happening within individual licensing boards and accrediting bodies, and it's important to be conferring with your licensing body, accrediting body, your institution, your facility, because sometimes these policies or their stance lines up and sometimes they're in conflict. And so staying attuned to this shift, particularly in our current times, is highly important. All right, moving on through then the rationale for telesupervision. So in living through the pandemic, really telesupervision became essential to maintain our training and also uphold safety of public health. And there was a rapid transition, whereas prior, some programs may have been implementing some degree of telesupervision, but suddenly it was everywhere and in all places. And when we look at telemental health, and we're focusing more on the mental health side in this piece of the literature, that our references are below that are a little cut off in the banner. The results are comparable to in-person care. So the expectation that you would be able to uphold some of the same quality of supervision when you shift the platform is a reasonable expectation. But it's also important that we're really thoughtful about how are we doing that and enables telesupervision to still be successful, because we do not want elements of rigor to be compromised when we shift to modality. All right, so what we know and what is yet to be known about telesupervision, a little bit, we're in a tip of the iceberg's state of being with our current understanding of the literature. And there are things going on where we're learning every day, but it's important, again, that we're keeping our eyes and ears open to what is happening within the evolution of literature, because things will continue to grow and our knowledge will change, and how this informs policy is still an ever-evolving process. So let's look a little bit into the telesupervision literature base. It is an increasingly growing literature base. So if you looked prior to the pandemic, it was really, and Erika and I have a 2019 article prior to onset of the pandemic, it was really a much more limited literature base. And it is increasingly growing out of necessity and also availability of where you can capture your data, while it still remains primarily focused on trainee perspectives, satisfaction, and acceptability. And what we've found thus far in the literature is there's not key differences in things such as supervisory working alliance, perceived effectiveness, and that's important when we think about perceived effectiveness versus measured effectiveness, or supervision process when compared to in-person supervision experiences. And in general, there's high satisfaction with telesupervision. So we're going to look a little bit then at considerations for adapting to the telesupervision modality. So our hope in going through here is to provide a little bit of reflective thought as we look at our own engagement, whether you're in charge of a program, a supervisor yourself, or even an emerging professional who's going to be supervising in the future. There's a few projects you'll hear us reference. So we did a questionnaire to VA psychology, the VA psychology trainees and supervisors in August of 2020. So really beginning of the pandemic, even though at that point it felt like the pandemic had been going on forever. And we were looking at measuring the abrupt transition to telework, telehealth, and telesupervision. So 249 psychology supervisors and 134 psychology trainees participated in that. And then we have our ongoing Office of Rural Health project that Brad was referencing earlier, where we're exploring the feasibility and utility of a competency-based supervision framework to ensure effective in-person and telesupervision. And this is within rural VA psychology training sites. So we have 8 current sites, and this includes supervisors, trainees, and training directors, and we're hoping to expand in this next year to include 11 sites. All right, so this is just an overview of preliminary findings. And as I even am telling you these preliminaries, we really want to highlight preliminary as We are continuing to analyze our data, and within the next few months, we'll have additional reporting, which may or may not shift some of these results as well. So overall, we found few differences in supervision characteristics or quality based on modality. And when we're talking about quality, we're really talking about how often were you able to access your supervisor when you needed to in an imminent session? How often were you meeting with the supervisor? What was the regularity of receiving feedback? And how did, what were some of what we identified as essential elements of supervision? Were there any differences there? We didn't have patient safety issues reported. And this is really those times when somebody needed supervision and wasn't able to access it for an imminent need or oversight. Or was there a time that you needed in-person supervision and there wasn't anyone available? And we haven't found those. What we have found, though, is that people are doing a good job of setting up thoughtful coverage. And what is the plan you have to make sure that that's in place? And then technology issues were relatively infrequent. So when we looked at how much disruption is happening within the supervision process simply from technology issues, it was actually much more minimal. And of note, people participating in these projects are doing both a combination of on-site care and telework. So we didn't manipulate any variables. We're really just gathering data in the real-time use of both in-person and telesupervision. So we didn't find it, we have thus far not found any differences in supervision meeting consistency, with some evidence of trainees access to supervisor when telesupervision is included. And this really is leveraging technology in a way through whether it's Teams or another form of chat or being able to virtually enter a care room, and the ways that we can leverage technology so that access to the resources increased for the trainee. And how much live observation are we doing? So regardless of our discipline, what I'd want to highlight is there is something different about directly observing someone that we're supervising versus them just reporting back. It almost becomes a copy of a copy, and we won't dive into the literature supporting that, but there's a reason that increasingly, at least in American Psychological Association and accreditation, the invaluable way that directly observing a trainee influences the quality of supervision you can provide. So there is some evidence that we have that there's increased access, and this is really because there's different ways that you can then do live observation. If someone's over telehealth, it's easier to click a link and join, potentially, than walking down the hall. And so again, that would matter a lot of what's the modality of the treatment that's also being done as well. And then critical supervision elements is what we identified as some of those essential elements, and this includes everything from modeling, giving a feedback. They appeared to be addressed in most meetings, regardless if it was in person or telesupervision, and the working alliance seemed to be maintained across modalities. All right, so when we think about being mindful of telesupervision or areas that we'd want to be particularly mindful of, it's really thinking about some ways that when we referenced being thoughtful earlier, these are some of the things we're talking about. So there's less dimension and knowledge of the trainee when we're engaging in telesupervision. So within in-person, and this is really mirrors telehealth. So in person, you may be able to see gait, nonverbals, all sorts of other expression that within telehealth you may have, or telesupervision, a more limited scope because it's what is within the camera view on the screen. And so if that's the case where we know that we're going to have less data, what are we doing that ensures we're kind of checking our own biases? Am I able to appropriately evaluate the trainee by gathering additional data? And this could be, I'm working in a team environment and I have collateral data. There's multiple supervisors involved. There's multiple modalities of care that we're looking at. And are there different ways that I can then leverage my team environment or even look at what are the different ways I'm gathering data regarding the trainee to understand them and to also then do a good evaluation. So we did not want to unintentionally fill holes in our information. We want to intentionally figure out how are we filling in this gap, and also thinking about, am I proactive in reaching out to the trainee, which is consistent with competency-based supervision, versus passively waiting for the trainee to bring problems to me, which may be further exacerbated in this modality. We also would want to think about transactional interactions. And so if you're thinking about our limited time is over screen, and when we're done, we click our red button and we leave, and we will not have more informal interactions, am I doing an intentional investment in priority of building rapport and in the relationship in a way that fits within the time that we have together, if we're not going to have other interactions that are helping build this relationship? And do I have enough modeling time that I'm building in as well? Am I maintaining focus on the session, or is my email open, my Teams open, and suddenly actually, when this is reporting from some of the data we gathered, you're responding to messages at the same time, and you're actually not fully attending to the supervision in the way that you would if your other electronic devices were turned off? And how am I making sense of nonverbals and the expression of empathy? So making sense of nonverbals, for some in our data, there was a evening of the power playing field where people felt a little bit more open. In others, there was a kind of feeling of disconnection or not feeling as much rapport or being misread and misunderstood. And that goes really into then when we have less dimension in knowledge of training, in what way am I investing in engaging expression of empathy and also building rapport, which is paramount to thinking about the development of a supervision relationship. And am I helping to then also build telepsychology competencies and using the competencies that we know work in telemental health or telehealth as bridging and as scaffolding within my telesupervision? All right, so the other thing we want to think about is thinking about a cultural attunement as essential. So if we have a client or patient that we're treating that is not geographically located within the region that the telesupervision or the telehealth is occurring, then what is the obligation of the supervisor to ensure that they're building competence in a way that actually helps the individual that they're serving? So an example would be is if I'm in Honolulu and I'm going to supervise a trainee that is located maybe within the state of Hawaii, and we're treating somebody who's located within rural Texas. We may really fall into like, oh, what a great job we're doing. We are helping this disparity. We are treating somebody in a needed rural location with our great skill, but we've missed a key element in our planning, and that's, do I have any idea what it is like for that person to walk down the streets of their community? This isn't just about their cultural environment, but it's even the cultural environment in which they live every day and they walk around, which is the context of their existence. And do we have that cultural knowledge apart from the other parts of intersectionality that we think about that allows good care and then good supervision to occur? So when we really think about where we're on the brink of the way that we can provide supervision and care looking completely different than it did even just a few years ago, what is the psychosocial context of the people we're treating, and are we competent and knowledgeable in that area to provide good supervision, or are we actually creating a disparity by actually having lower quality supervision and subsequent care as a result? All right. Moving on through, questions to ask ourselves. Do I have a foundation of supervision competency in the program? So you want to ask yourself, do I have supervision competencies to begin with? What's the supervision model that I'm working from? The cultural attunement I was just referencing, and the goodness of fit of the supervisor. We know this from the work we've done. If you aren't comfortable with telesupervision, you aren't comfortable in supervision competencies, you haven't worked out a good oversight plan, this is not going to go well. So where is my foundation of supervision competency? And just to highlight, supervision is a separate competency than just being a good clinician or a good provider. All right, next slide. What are the learning needs of the trainee beyond preferences? So satisfaction is important, but it's not everything. And so we really need to identify the developmental needs and interests of the trainee, and is the use of telesupervision adequately meeting the learning needs and goals. So someone can want to telework, someone can want to have telesupervision. It can be very convenient, but convenience isn't the reason to do it. It actually is, how does this match up to developmental need? How does this match up to what will actually provide a good education environment? And that's some of the critique we should give when research is only based on satisfaction, because it's a piece of the pie, but it's not everything. All right, next. Does the program have the infrastructure to provide telesupervision? Do we have reliable platforms, equipment, internet? Do we all know how to even use all of it, how to access it? And are we well set up within our SOPs, within our infrastructure of our system, how to do direct and live observation? And this should be that matches the modality of care that's being done of the trainee. And we just can't highlight enough that the direct and live observation is really irreplaceable, because relying fully on the self-report of the briefing of a patient or a client from a trainee, someone can't report what they didn't observe to begin with. And it's not any intentionality on their own, but they're reporting based on their developmental lens. All right. Does the program structure enable an approach that supports telesupervision? So is there one that enhances the learning environment versus universal application? So what's the rotation? And does it make sense to be doing telesupervision, or does telesupervision compromise it anyway? This would be, am I able to demonstrate the skills that are needed within the modality of telesupervision? Can I adapt and scaffold learning needs of the trainees? So that goes back into the demonstration. Is there a way that I'm going to need to intervene behaviorally in order to assist a trainee that cannot be done over telesupervision? And this could be the difference of like certain inpatient behavioral interventions when we think about mental health, or it can also be when we think about physical health. Am I able to help manipulate and shift the way someone's physically engaging beyond verbally, which may need an in-person presence? And we also want to look at how our policy of institution and programs support its use. Where's there flex and where's there not flex? And every institution's a little different. Okay. All right, so now I'll turn it over to Erika to describe strategies to scaffold training experiences.
Thank you, Shiloh. And I am just going to toggle the subtitles back on. I was noticing that it was struggling with the sharing piece. All right. So for the remainder of the slides, what we're going to do is utilize a competency-based framework to inform our approach to how we pivot and actually start scaffolding these strategies. And so this competency-based framework, for people that may not be as aware, it's from Fallender and Shafransky's work. It is considered interdisciplinary, gosh, I am stumbling on my words today, and meta-theoretical. So it is nice to have for this framework as we're talking about supervision that could cross disciplines. So essential in the beginning is setting a solid foundation for supervision. We recommend utilizing a supervision agreement or contract, or having some kind of really explicit conversation, ideally written down, that explicates what supervision is going to look like, how often it's going to be meeting, what will be covered in supervision sessions, all of the good information to establish expectations. Part of this should also include a baseline assessment of the trainee and their needs, as well as those supervisor competencies and areas of growth. Another important part of supervision that we'll be talking about is how to continue active engagement, regardless of modality. So inclusion of effective elements of supervision. We have a slide next to discuss those pieces, as well as Shiloh was saying, how we gather those multiple data points to inform our understanding of the trainee, their competencies, and their growth. And then lastly, ensuring that the logistics are very clear on how to use technology, how we're going to support a trainee in the event of an urgent need or crisis. And last but not least, as we are learning with technology all the time, the ability to adjust as needed. Perhaps that includes shifting the modality, the structure, whatever it takes to ensure that we're meeting the needs of both the trainee, the client or patient, and then the supervisor as well. So this checklist highlights those essential elements of supervision that we just discussed. It's a 5-item supervision checklist tool that was adapted from Fallender and Shafransky's work in 2015 and in further consultation with Carol Fallender. So the first item is, did supervision address my goals for both learning and my immediate needs for supervision? And then were diversity or multicultural identities of the clients, the supervisee, the supervisor, or any interaction of the above 3 different parties discussed and discussed in relevance to clinical conceptualization or treatment planning of interventions? Was there an active component? Was there an actual experiential component to supervision? And that could be active problem solving, it could be role play or modeling, or watching recorded sessions. Were my feelings or reactivity towards a client and or supervisory relationship addressed? And then was patient progress actually monitored, ideally through the use of measurement-based care or some kind of tracking? So these are 5 items that might help supervisors and trainees ensure that they're staying on course with regard to supervision. Some of the early data that we received from the first survey noted that in the abrupt switch, the supervision focus may have shifted a bit to back to report building or kind of discussing the stress of the current pandemic and social justice pieces. And so this might be a way to bring us back to effective supervision. Of course, last but not least, any areas or items to be addressed at the next supervision session. So the next series of slides is about how to ensure that we're fostering access and communication, as this is another essential component of supervision. We have here a potentially useful, what do we call this? A diagram, a form here, we'll call it a form, that can explicate primary supervisors, secondary supervisors, and even a tertiary supervisor for a trainee to access and how they access that supervisor. So just as in the case of in-person supervision, trainees need to have access to their supervisors and to know how to access them. And ideally, this coverage plan, even in the case of in-person supervision, is multi-layered so that a trainee in the heat of a moment isn't struggling to find who can assist them with their question. So it used to be that we would have the primary supervisor, typically the supervisor that they're meeting with individually for weekly supervision. And we used to have a backup supervisor identified. But what was noted is that kind of backup language or terminology often meant that that supervisor wasn't really tuned into needing to be on backup or be poised and ready. So there was a switch to calling this a secondary supervisor, with the idea that being noted that, oh, I am Shiloh's secondary supervisor today, I should be ready in case Shiloh has a need for me. And then typically that tertiary supervisor is a training program director or someone else affiliated with the training program and the trainees that they could go to for support. So just as in the case for in-person supervision, and in accordance with your discipline and accreditation, there should be regularly occurring supervision. And then there should be on-the-spot or unscheduled ad hoc supervision for those emergent or non-emergent concerns that might pop up throughout the day. So regularly occurring supervision, again, in accordance with your licensing boards and accreditation standards, it's typically scheduled and prepared for on a weekly basis, should be exactly the same as in-person supervision. And there's some emerging evidence that, excuse me, engaging in telesupervision, particularly for supervisees that are engaging in telehealth, can increase that teleconferencing skill set, but also gives the supervisor a window into the trainee's work environment. Are they always to the side in the camera? What are they wearing here that might contradict with how the camera is going? What's going on in their background? That can be helpful as well. And then there is some emerging evidence, like I mentioned, that something about the video telehealth modality might actually increase disclosure at times, and that there's a greater emphasis on the verbal aspects of communication. Shiloh was highlighting this as well, and that might be a benefit to supervision. Still looking for more evidence to come and research to come on these pieces. Now, pivoting to the on-the-spot and ad hoc supervision, regardless of modality, we want to ensure that there's the same level of access to supervision. So a supervisor should be available and capable to join a session in a timely manner. This means there might need to be some scaffolding upfront to practice how to join a telehealth session, what that'll look like, and what the expectations are. And then some examples of ways to be readily available include having an instant messaging option. In our VA system, we use Microsoft Teams, for example, and having that open and visible. Having a cell phone on, if that is your primary means of emergent communication, and making sure that the screen is up and in line and in view. And then some coaching around languaging around the urgency. So for example, in my clinical setting, we often would put non-urgent in parentheses before the chat to indicate that this is something that can wait until you're able to focus on this matter, versus urgent or something like that in all caps. So we've discussed the who and the how. It's also important to think about when to access supervision. So part of this is both that on the part of trainees and supervisors having a knowledge of each other's schedules and availability. So a trainee should know when a supervisor might be available or not, and when a secondary supervisor might need to be requested. And the same on the supervisor side, it's helpful to know when a trainee might be engaging in a potentially sticky session or what's going on and to be ready. And then relatedly, it's important that trainees and supervisors establish expectations for when an ad hoc supervision should be sought out, when something does rise to the level of an emergency, and that can be an ongoing discussion and a growth curve for supervision. So we're going to pivot next to talking about oversight. We just talked about access and then as one of the essential elements of supervision, and the next category is oversight and that active and experiential portion of supervision. So the amount of oversight is based on trainee competency. And so you can see that there's quite a range here, from as high of a level of oversight as being in the virtual room with the trainee, so that means co-facilitating sessions or live observation, to being readily available, that a supervisor could be called upon to join a session or to assist when needed. And I'm going to try to motor mouth here a bit because I see we're starting to run close on time, and I want to ensure there's room for questions. Please do pop any questions in the Whova system so we can address them at the end. Now, this intensity of oversight should be adjusted based on where you are in the trainee's telesupervision and telehealth training experience. So again, relying on those baseline competencies and part of that pre-supervision work to understand the developmental needs of the trainee. Is this someone in their practicum or internship or postdoctoral training experience? It's helpful at the onset to start at a higher level of observation so that you can see where the trainee is, and then titrate that observation according to demonstrated competence of the trainee. And then throughout the telehealth and telesupervision training experience, monitoring the competency development and adjusting the intensity and type of oversight accordingly. It's important to note that it's good practice to be willing to step back to a higher level of oversight when there's a need. Perhaps a trainee is learning a new evidence-based practice or starting a new rotation, and it's helpful to come back to that within the room observation and then step away as needed. So direct observation, it really depends on your accreditation standards, your licensing boards, and so forth. We can't recommend it enough, as it is how we directly observe the clinical competencies of a trainee, and there are different standards for that. It's important to know the various ways that you can maintain direct observation, if that's joining a video session, a three-way call, or being on speaker, or even recording a session to be later viewed. So moving into scaffolding to enable training. So these are training in the profession-wide competencies that really vary based on your discipline and profession. And the gold standard here is not to alter the competencies based off of the modality, but instead to overtly translate how we measure progress in these competencies based off of what we can see and the data sources that we have. So for example, these two competencies come from the psychology profession-wide competencies, but a trainee who is used to in-person care and work may struggle with how they adapt the profession-wide competency related to consultation and interprofessional and interdisciplinary skills to the virtual setting. And so there may need to be some overt translation on the use of NVA, Microsoft Teams, and the electronic health record, and so forth. I see my 10-minute cue here, so I will swiftly wrap up. And then the competency related to ethical and legal standards could be met via talking about informed consent for telehealth and telehealth documentation and other ethical standards. The last essential element of supervision that we want to share is ensuring that regardless of modality, we are upholding the provision of feedback. So just as with in-person supervision, we have to be intentional and consistent in how we provide feedback and how we provide it meaningfully. Part of that supervision agreement or contract can be discussion of how feedback is received and heard. Does it need to be verbal or written, or what ways do we facilitate that feedback communication? And then the last part of this is somewhat related. It's a little bit onto the next topic, which is thinking of the training programs and what logistical structures need to be in place to allow for the virtual provision of feedback and the virtual modality of supervision. Translating documents into virtual electronic versions, record management, allowing for direct observation, and so forth. So as we wrap up here today, we want to leave you with some key questions for you to all consider as you consider your own supervision practice. Regardless of the modality of supervision, is the supervisor able to engage in direct observation? And direct observation appropriate for the current clinical setting? Is the supervisor able to ensure trainees have access to scheduled ad hoc and emergent supervision as needed? Is the supervisor able to uphold critical competency and learning goal development? Is the supervisor able to effectively deliver and receive constructive feedback? Is the supervisor able to model critical clinical skills relevant to the clinical training area? Is the modality of supervision optimal for the care setting? And is the supervisor able to intervene as needed to assist the trainee? And last but not least, do we have the cultural knowledge to provide care and supervision to the clinical population being served? So at this point, that concludes the content of our slides, and we have just a few minutes left for any questions or discussion. And we so appreciate your time and attention today.
Wow, Dr. Jordan, Dr. Shearer, that was fantastic. I just love the way you take these complex constructs. They're so important and put it into practical terminology that people can actually use and implement in their work. So thank you. We have one question before we get to that. A recurring question has been coming through is how do I get copies of the slides? So what if the speakers agree at this conference to share their slides, they will be posted on the BHI website that we introduced earlier today, and it's very available everywhere. So you'll be able to go there and get copies of the slides if the speakers agree. We're going to post them as soon as possible, hopefully, definitely within the next 2 weeks. So they're all will be available provided the speakers agree. We do have a question. The question is, I have received increased requests by universities to provide master's level internships / practicums completely virtually. Do you have thoughts / research on effectiveness of this model of training in supervision?
I think that, so the research is primarily done, and this is, you know, without inferring which discipline this is, on internship, postdoc, so more advanced developmentally. So when we think about, excuse me, that developmental level, it would be a greater risk than it would be for internship and postdoc. So we don't have data to say you can't. My opinion on it would be, if you think about developmental need and developmental level and what a completely virtual practicum, what are the skills they're not developing that are foundational, that I wouldn't know are going on if it's only a click enter, click leave type of situation. It is a setup for having potentially less oversight. As well. And in our project, we're not including practicum, partly because, you know, our VA higher ups have said, you know, at that developmental level, that might be too much of a stretch. So I think the data officially is still out, but my opinion would be a little bit hesitant to think, what is the full intention? Now, if it's a very limited in scope type of practicum, I could see that potentially working out. But I would really kind of have more hesitation than I do when I think the further we advance developmentally. And that's consistent, I think, with some of the data we do have. Erika, I don't know if you'd add something different, but that's my response.
What she said, right, Erika? Well, that was just fantastic, you guys. I'm so thankful you guys came today and put this in terms even I can understand. So thank you. Thank you. And Eric and Shiloh, I owe you two big. Thank you.
Thank you, everyone.